Good afternoon, everybody. I thank Society for the invitation. My talk won't be as complex and as difficult as the cardiologist and the pharmacist. It's going to be down to the point. I'll try to share with you some knowledge about destination therapy and share with you some knowledge about our local experience and project the future for destination therapy in our country if we have a chance to go. So we'll go over a definition, review some clinical indication, understand the VAD care requirement in the hospital and home environment based on our experience, and then go over our own local experience in the VAD program in our center. So by definition, it's an implantation of an LVAD with an aim of providing permanent circulatory support to the people of advanced heart failure who are ineligible to heart transplant. So as we know, there are enough data out there to say that heart failure is a burden. Heart failure is worse than a cancer. There's about 34% of cardiovascular-related death in the US is related to heart failure. Rehospitalization more than 50% in 6 months in the US. Cost is big. There's about 400,000 cases registered in Saudi with heart failure. Advanced heart failure who required hospitalization advanced therapy is between 30 to 40,000. There's a scarce of number of heart transplant in Saudi Arabia. It's not even deserve a slide. There's about 135 cases in the last 30 years. As per our registry and per our Center for Organ Transplant, we are in need for 500 heart annually to meet the demand. So what are the goals for any heart failure management? The goal is to improve quality of life, to slow the progression of the disease, and to reduce mortality. Primary goals for any destination therapy is to prolong survival, to improve the quality of life, to minimize harm. So we are looking for a device that with lower infection rate, lower bleeding, lower thromboembolic event, and device that have minimum problems as far as malfunction concern or failure. This is a slide, it's a cardiology slide looking at the progression of the disease of heart failure, and you can appreciate there is a big gap between stage C and stage D. And to the point where you reach that you're requiring a VAD or transplantation, you reach almost to the top of the ladder, which is an advanced therapy. So the patient already exhausted all the resources. By the time we get to this level, we're talking about a patient who's literally bed-bound, frequent visit to the hospital, rehospitalization. So we reach an exhausted all resources to get to this point. And that's going to get to the end of my presentation where I will throw some argument about this level. So heart failure, if you appreciate this slide, so we're talking about class 1 symptom, we're well with moderate, and then you have the slippery slope and the steep down so fast. So if you are lucky to catch them at this level and treat them properly at this level, but by the time they get to class 3 symptom, they're going downhill from there. So then when you're looking for more hospitalization, advanced therapy, you're looking for inotrope support, and then they become a burden for you and for long-term management. Heart transplant, as I said, in the US, we're looking for numbers above 2,000 a year, and the number is plateauing or going up and down, but without any hiccups. This is the slide from SHFG. So we are on these red whiskers. So everything outside Europe and the US is on these red whiskers. So imagine we're part of this red. So that's why I said the transplant in Saudi does not qualify to go on a slide. So we know about the evidence. The evidence is very strong about the recommendation for VAD therapy, and it qualified to be class 1B evidence. So an LVAD or BiVAD is recommended in a selected patient with end-stage heart failure, despite optimal pharmacological and device treatment who are otherwise suitable for heart transplant to improve symptom and reduce risk for hospitalization. So the indication are clear. So life expectancy less than 2 years, transplant ineligible, failure to respond to medical therapy for at least more than 6 days in the last 90 days. Ejection fraction less than 25%, refractory cardiogenic shock or cardiac limitation, peak VO max less than 12, inotropic dependence recurrent VT or VFib that are untreatable or untreatable arthralgic substrate. This is the slide which was shared by my successor, or the first speakers. We know the Intermax. Now, as per the guidelines, we're looking for this group, which is level 3 and 4, and level 1 and 2, as the one who qualified their guidelines to go for the LVAD transplant. Beyond that, we're looking for SHA-MC support, or looking for a waiting list and medical therapy. I'm going to repeat this slide at the end of my presentation to throw an argument about if this slide is really valid in our local program or in our local experience or not. Contraindication. There is a long list of contraindications. I highlighted 2 contraindications because we got burned really from our local experience by these 2 contraindications, which they were overlooked or they were taken lightly, is underestimating biventricular failure in a patient older than 65, and we fail to do really proper psychosocial analysis for our patient pre-transplant, because what comes to haunt you after surgery and home care setting is the psychosocial status of this patient post-op, which becomes a burden really for any patient to leave the hospital. So we do have some history on the LVADs. It's an evolving technology. We're moving now to a 3rd generation, so the technology is going really hand in hand with the desire. However, we need to move as well with the technology in terms of recruiting cases. So we went from pulsatile pump to continuous axial flow pump, and now we're moving to the rotary pump with non-contact bearings. For just knowledge sake, so this is one of a Biomed's pump. It's not for destination therapy, it's for short-term use. Thoratic, which is 1st generation, it's not registered as a destination therapy. It's used as a bridge to recovery, bridge transplant. HeartMate 2 is a destination therapy. It's for long-term use. It's pulsatile or axial flow. So HeartMate 1 and HeartMate 2, the technology moved or changed for a reason that I will mention later. This is what HeartMate 2 looks like in a patient or in a hardware. It's a left ventricular assist device registered for destination therapy, and we will share our local experience with this device in particular. The issue here for a surgeon is not to implant the device. I think the easy part of the whole program of any assist devices is doing the surgery. The difficult part is recruiting patients and taking care of these patients post-op. So, small comparison between the two. What mattered to you the most is more advanced technology in HeartMate and hardware, and as far as valveless, and it's an afterload sensitive. There is no valve in it. There is no vacuum assisting fill. And the pump output varies over the cardiac cycle. A slide was brought up by the first speaker, just to show you what's the survival curve for comparing pulsatile, continuous flow, and medical therapy. Regardless of technology, 1st generation or 2nd generation, whatever you do to the patient, you're better off doing it than putting a patient in medical therapy. So we know for a fact medical therapy is inferior to any other intervention. Again, comparison between continuous and pulsatile flow, and we're going with a new generation. Seem to be with continuous flow, we're doing better than pulsatile flow. This is the result of hardware, which is a 3 years. Clinical trial, 77% survival after 3 years, and the commercial patient, there was an 87% for 1 year. So it is here to stay. And this is an evolving technology, as I said, and there is one coming out in the near future, hopefully after they close the trial. Different studies showing a very promising and encouraging result for 1 year, for 30 days, 6 months, and 1 year and 2 years, looking for survival around 68%. So what's the benefit of the new technology? What's the benefit of continuous flow? Why we're moved out of pulsatile flow? It's a single moving embolar, so the blood is immersed, it's hydrodynamic, no internal valves lead to less wear and tear, it's more durable, it's a silent. So the patient won't hear anything. So the click of the valve and the reservoir really create a lot of noise. So having a device with a silent mode, it means a lot to the quality of life for a patient on a daily basis. So what are the basic, what do we worry about VAD management? They are preload dependent. They are ECG dependent, very sensitive to afterload. Anticoagulation is important. They are prone to infection, bleeding, thrombosis, and mechanical malfunction. And as I said, and I showed in the previous slides, there are key differences between pulsatile and non-pulsatile device. So the key about this non-pulsatile or continuous flow, it is you can't ask the nurse to feel the pulse for the patient because she won't feel anything. So you need an arterial line or a blood pressure measurement. They are very afterload sensitive. So it's very important that the pump is not going against an afterload. It's very important that they're very sensitive toward afterload reducers. Volume is very important. Patient is hypovolemic. They go in a mode of a low flow. So it's important to optimize the volume in this patient. Anticoagulation, as much as it's crucial, as much as it's important, again, it's you have to play it in the middle where you don't want to overdo it, and you don't want to really deprive the patient from it because the thrombosis rate is less on the continuous flow. However, it's important to keep the patient at a certain level of anticoagulation where it's safe for him not to thrombose his device. You could see a patient, you could have an arrest in the CCU, a VFib arrest. Whatever you do, try everything but avoid chest compression over the patient because that may damage the device. So you could have somebody who's fibrillating for hours, but he's still hemodynamically stable. So jumping into calling a code for this patient is very crucial. Don't underestimate the heart failure post-implant. These patients still do need to be treated for their failure. They need, as they said, they need to get adapted to the device and instead of having the device adapted to them. So if you list the problems, there are too many problems. And you can easily look at them and treat them. Bleeding is a problem, thrombosis is a problem, infection probably is the leading cause of deaths on these patients. As I said before, we underestimate sometimes the RV function on these patients. So RV dysfunction, it is one of the burden on these patients post-op. Suck down phenomena, as I said, they are preload sensitive. So you have to be very careful with the volume status of these patients. Device failure, I will show you some evidence in the later slides, is not of an issue as much as you would think, especially with a newer device. Hemolysis, the newer device have lesser hemolysis than a previous device, still exists, but the good news is they go on a transient stage and then they normalize. So if you have hemolysis in the first 4 or 6 months, eventually this problem won't go as chronic. Look at the slides, and that tells you what could go wrong with the device itself. You could have a problem with the inflow cannula. You could have a problem with the pump. You could have a problem with the battery. You could have a problem with the drive line. You could have a problem with the controller. So it's not a complex device. So you looking for a problem to explain what's going on, it's not a complex issue. Handling the problem and treating it the right way is the issue. You do have some long-term complications like GI bleed and reported 13 to 40%. CVA is an issue, which is reported 70%. Hemolysis, as I said, and it may increase the mortality by 25% over 6 months. So what is the evidence here? Are these devices safe? Are we offering the patient, when we offer him this, are we looking for the best interest for the patient? Let me just shed some light on some of the evidence about the efficacy of these devices. So as far as survival rate, there is no argument about it in 2 years. We're better off with a device than a medical therapy. As far as comparing pulsatile versus non-pulsatile, we know that continuous flow do better than pulsatile flow. As far as quality of life and 6-minute walking, you're better off with these devices. And whatever score you use to measure the quality of life, there is a body of evidence to support the quality of life of this patient by far better than being on medical therapy. Are they safe? We know there is a survival benefit. So death caused by device failure is reported only 1% in a continuous flow devices and 2% on patient with pulsatile flow. So it's really not an issue of having device failure. So the device, the least of your concern is this device failing on you and stopping all of a sudden. So there is enough backup in this technology to support the device. Stroke is 8% reported and in continuous flow and 7% in the pulsatile flow. Right heart failure is in 20%, as I said. This is something that you have to really evaluate before you're embarking on these patients pre-op. Cardiac arrhythmias, lots of them, despite of what you could see post-op from arrhythmias, are labeled to be a benign and can be managed medically. However, you still you have to look at them seriously and make sure that you are not dealing with acute coronary syndrome under the umbrella of VADs. VAD-related infection, it's an issue, as I said, and this is one of the most important things for caring for these patients post-op. Pump replacement needed in 9% of the cases, pump thrombosis, bleeding. So these devices are relatively safe and they are effective, and you're really not offering the patient experimental therapy. You're offering a patient with a very strong evidence that they will do well with it. So what is our experience, our local program? So we decided to set up a local program looking at the number of heart failure cases, the scarce of donors for heart transplant, looking at the data everywhere, and we thought of embarking on a VAD program in our hospital, being a tertiary care hospital, accepting referral from everywhere for the Ministry of Health. As a strategic plan that we decided to set up a program as a destination therapy. It was a teamwork. It wasn't a one-man show. It took a lot of meeting, a lot of discussion, and we seeked the advice and help from the expert on the field, locally and internationally. So we set our goals to support patients with heart function, improve their quality of life, strengthen their ability to participate in the activity, and allow them to be discharged in an outpatient setting for the rest of their life. What we did, we established a VAD team. We set up our program guidelines. We set up our education with the health educator and our VAD coordinator, and we communicate with our vendors, and we purchase a device after deliberate discussion and workshops. So we formed a team, 2 surgeons and 2 cardiologists. We had 2 VAD coordinators with a background of nurses, senior level nurses, and they are really the backbone of this program. We have bedside nurses, a social worker, home care, pharmacist, a dietitian, respiratory therapist. It is a big team, but we cannot do it without really having everybody giving his input on how to look for this patient. And we set up a flow chart from getting the patient from the clinic to the hospital, to the OR, to ICU, to the ward, and back home. And we really revised this flow chart in several occasions to see exactly who is the key player on every part of this pathway. So the responsibility about the VAD team was to facilitate inpatient and outpatient. Really moved, So I have to move with the slides. The time really. So this is our team and our meetings. There are some familiar faces. This is the handsome guy over here. I don't know if he's familiar to everybody. So we had several meetings. I will need an extra 5 minutes probably, Adil, if it's possible. Adil, I'll need 5 minutes. Can we? No? So we implanted two cases in December. Our daily check, recommendation. So self-care management. Patient and family education is typically include, as I said, we got the family engaged on the care for this patient, about the device component, device function, and we listed didactic teaching and demonstrate the return to regular reinforcement on the device. We alert them about the warning and emergencies, what could go wrong with the device, what you should not do, what you should do. We evaluate the patient and their readiness for discharge, several sessions with the family and the patient about his readiness for the discharge. What do we take to get the patient home? recovery, education, and setting up a proper home environment. Home care were involved. They evaluate the home properly after several visits. I just need 2 minutes probably. This is one of our patients, the day of his discharge. This is the celebration of Eid, last Eid with him and his family. With the permission, he gave us his photos. He's back to work. You can see this is the drive line for the device, and this is where the battery is. So he's back to work, and he's doing half of his usual duties, and he's happy he's been checked as an outpatient. Our VAD clinic is set up to check this patient on a weekly basis, do echo routinely and blood work. I'm going for this slide again. So this is where the guidelines is. We're looking for 3 and 4 level of Intermax. This is what you should avoid, because I think you're taking the patient nowhere if you implant a device. And you should not really entertain a device therapy for this patient. I think with what I'm looking for is to move our indication to a healthier group, or class 3B, or walking wounded, in order for us to have a better outcome and a long-term survival. In summary, so the management of the advanced heart failure is a dynamic process that requires frequent reevaluation. Timing of the LVAD placement is critical. LVADs for destination therapy have been shown to improve mortality rate and quality of life. There are short-term VAD options available in an emergency situation. VAD implantation is the only option in compensated heart failure with a limited transplantation, as we have here. Program should be structured and well organized. Destination therapy or bridge to candidacy is a very acceptable solution. Experience should grow in the region with the world experience. There are some difficult cases where the future is. We have to improve our patient selection. We have to be less invasive, no bucket, no drive line, fewer complication, aerial implant, and less ill patient. We have to be, as this slide, too many of us reaching for the patient instead of waiting for the patient to reach us to have better outcome. This is our VAD team contact. We are accepting referral from anywhere. We have our hotline 24/7. We have our email. We're ready to receive any cases that require evaluation or any VAD consultation. Opening file is not an issue, but we need to open line of communication. It's an invitation for everybody to consult with us, and hopefully we can improve the outcome of our patient in the future. Thank you very much.